Good morning. I'm Gordon Smith, the state's director of opioid response in Governor Mills' office. Thank you for joining us this morning for an hour webinar with Jim Gioia and Shasta Minery, and I'll introduce them in a moment. They're going to talk about the Overdose Response Strategy and the activities of HIDTA, which stands for the High Intensity Drug Trafficking Areas. And we haven't frequently in this space talked a lot about public safety and the intersection of public health and public safety. And I really appreciate Shasta and Jim being with us, and you're going to get a lot out of it. I want to make a few preliminary comments. I want to remind you that we were already making plans for the governor's 7th annual Opioid Response Summit. It will be July 10th at the Augusta Civic Center. And we'd be interested in your thoughts directed to me. I'll put my contact information in the chat. That we're considering, based upon the previous 6 years' experience, of having a 2-day summit and not trying to cram everything into one day. And we realize that many people, can't always leave their regular work or families for 2 days. So, but we also see that there might be some benefit. So if you have any thoughts on that, I would welcome that. We have a planning and advisory committee to the summit. Now has become such an important part of our activity. As you know, we regularly get 12 to 1,400 people. That's become an important annual event to them. We'll continue these monthly webinars the first Friday of every month from starting again in January, taking us through the summit and in the next week or so the topic for January and for February. And then finally, I just want to thank all of you for not only supporting these webinars, but all the work that you do that is in the community and is no doubt influencing and one of the causative factors to our declining mortality and total overdoses. As of last week, we've had a decline in deaths compared to a year ago of about 21%. That's about 118 lives that people who are here today with us, that if we'd been kept on the same pace as even a year ago, would be gone. And this 21% decline is on top of the 16% decline the previous year. It's a wonderful trend, and no one can really tell us causally what absolute factors are causing that. Most of the researchers across the country, where there's been a 14% reduction, believe that it's a combination of all the positive things that are going on, from more treatment being available, certainly on naloxone saturation policies in Maine. We've got our 32 liaisons on the ground co-responding to overdoses, supported by now 9 recovery coaches. We also have, as I say, have a lot more treatment available. Having said that, not all the other states are doing all those things, and they've also seen a decline. And so we absolutely believe that some of this is the source of the drugs, the adulteration of the drugs with more sedatives. It's a complicated thing. And but it's all good that it's moving in the right direction. But no victory laps. It still means that at the end of the year, we'll be announcing that, nearly 500 people in Maine have died, well over a person every day. And yes, it's better than 700. It's better than 600, but we still got a lot of work to do. And that's why you're here with us today. But I think it is important to have hope that we're going to continue our work and put resources to the problem and try to make things better for people. So with that, let me introduce Jim Gioia and Shasta Minery, excuse me. Jim is currently employed as the Drug Intelligence Officer for the state of Maine through New England HIDTA. And I mentioned previously what HIDTA stood for. And that is all part of the Overdose Response Program. So in addition to providing intelligence support and coordinating with law enforcement officers investigating allegations of trafficking, he also works with public health professionals to reduce overdose deaths through innovative strategies and evidence-based interventions. He's had a long history as a patrol officer, detective, special agent, task force officer. Jim and I first got to know each other when he was with the Attorney General's office investigating cases at the Board of Licensure and Medicine and the Osteopathic Board, where I was quite involved in my previous position at the Maine Medical Association. So thank you, Jim. I'm going to introduce them both. I think Shasta's going to start, but let me tell you a little bit about Shasta Minery, who is newer to the public health analyst position. Jim was already there when she arrived. She can tell you exactly, but it's probably has been nearly a year, Shasta, by now?
About 10 months.
10 months. But she is, in fact, the public health analyst in Maine for the CDC Foundation, again, working on the overdose response strategy. She also is a licensed clinical social worker. She works on a per diem basis at Maine Health at Penn Bay, where she provides important clinical services with providing support to individuals and families experiencing mental health and substance use challenges. She's worked as a crisis response worker, clinical social worker on an inpatient psychiatric and addiction unit at Penn Bay. She's also very active in her community. She's been on the local school board and done a lot of important things, and has a family on the mid-coast, living in the mid-coast area. So with that, I'm going to turn it right over to Shasta and Jim. They're going to present together, and I think Shasta's got slides and is going to start. You can put questions in the question and answer. I'm not seeing the question and answer thing on my screen. Lorena, maybe you can help me with that. Isn't there a place on this Zoom for questions and answers other than
there is a Q&A section at the bottom. For most people, I believe it will be to the right of the screen. You'll see chat, react, raise hand, Q&A with a question mark.
Is it under that react thing?
No, it's over a few more buttons over. It's right next to show captions.
Okay. In mine, it's under a little circle that says more.
Oh, yes, that does happen sometimes. And everyone's screen is a little different.
Yeah, that's where we'd like to have you put your questions rather than using the chat. Put them in that box. I will respond. I may respond to some while Jim and Shasta are speaking, but if not, I'll moderate the response to those questions after the presentation. So with that, take it away, Shasta.
Thank you. Just waiting for the slides to pop up.
They've popped up, but they're not in presentation mode yet, but they are now. Thanks.
Okay, great. All right. Thank you for the introduction and for inviting us today, Gordon. We'll start the presentation with a federal acknowledgement. Then we'll share information about the ORS program, our work, and how Jim and I collaborate with each other and our partners. Jim will wrap up the presentation with information about current drug trends, and hopefully there will be some time at the end to answer any questions. So this presentation is supported in part by the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services as part of a financial assistance award totaling $11 million, with 100% funded by the CDC and HHS. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by the CDC and HHS or the U.S. government. So what is the Overdose Response Strategy Program? The Overdose Response Strategy Program that Jim and I are part of, also known as the ORS, is a unique national public health, public safety partnership between the High Intensity Drug Trafficking Areas Program, or HIDTA, and the U.S. Centers for Disease Control and Prevention, or CDC. The mission of the ORS is to help communities reduce fatal and non-fatal drug overdoses by connecting public health and public safety agencies, sharing information, and supporting evidence-based interventions. The program began in 2015 with only 5 HIDTAs, including New England HIDTA, covering 15 states. And Jim will discuss more about what HIDTA is later on. Today, it covers every state, including Washington, D.C., Puerto Rico, and the U.S. Virgin Islands. The ORS is carried out by teams of drug intelligence officers and public health analysts in every state. These teams collaborate on drug overdose issues across various sectors, states, and territories. The ORS program emphasizes the strength of collective efforts, bringing together individuals with diverse perspectives to work towards a shared goal. Whether you are on the public health side or the public safety side, you hold only one piece of the puzzle. However, we can learn from one another to develop effective strategies that truly work. For example, Jim and I come from different backgrounds. I'm a clinical social worker with several years of experience in healthcare, providing support to individuals and families experiencing mental health and substance use challenges. At the same time, Jim has an extensive background in law enforcement, having served as a police officer in Maine for many years. We often find that we do not always agree and have different viewpoints, which means we may not always meet perfectly in the middle. However, by sharing our ideas and being willing to move a little closer to the center, we can accomplish incredible things. The vision of the Overdose Response Strategy program is that real progress can only be made if we work together. So the ORS program allows us to collaborate across public health and public safety sectors by sharing data, insights, and trends we are seeing related to drug overdose in our communities. We can then inform and help local communities develop local solutions to reduce overdoses and save lives. So as mentioned previously, the ORS is implemented by teams of drug intelligence officers and public health analysts who work together on drug overdose issues within and across sectors and states to promote public health and public safety efforts. Before the ORS program began, the Centers for Disease Control and the Office of National Drug Control Policy were addressing different sides of the same issues and had not formally collaborated. Collaboration between public health and public safety is a critical step to saving lives and responding to the drug overdose crisis. The ORS exemplifies public health and public safety collaboration at the federal level, as demonstrated by continued investment from the Centers for Disease Control and the Office of National Drug Control Policy. By sharing information across sectors, the ORS is growing the body of evidence related to early warning signs and prevention strategies. Information and data sharing are key strategies of ORS teams in efforts to improve collaboration across state and local agencies and targeted overdose prevention. Public health analysts can obtain information more quickly than in more traditional settings, and drug intelligence officers provide timely information about newly emerging drug trends and threats in their states and regions. Oftentimes, Jim gets me through public safety doors, and I get him through public health doors. In fact, Jim and I have found ourselves in meetings where he may be the only public safety representative at the table, or vice versa. I might be the only public health representative among public safety officials. By sharing information, we hope to assist individuals and communities in making healthier and safer choices. Many metaphors can describe the role of the public health analyst and drug intelligence officers in the ORS program. One of my favorite parts of this job is the connections, partnerships, and relationships Jim and I have made, which Jim will discuss further in an upcoming slide. We work together, or we work to create common ground to not only form partnerships, but to embark on effective collaboration that results in data-driven strategies between public health and public safety. There are 4 overarching strategies that help shape public health analysts and drug intelligence officer priorities within each state. The first one is related to sharing data systems. The second supports evidence-based response efforts. The third is related to designing and using promising strategies at the intersection of public health and public safety. And the fourth supports the implementation of evidence-informed prevention strategies. While the ORS's larger strategies are broad, the activities associated with them are tailored to meet the specific needs of each state. We believe that increasing data and information sharing, adopting evidence-based interventions and prevention strategies, and working across health and safety sectors are more effective ways to prevent overdose. So how does the CDC Foundation work with the CDC? The CDC Foundation helps the CDC save and improve lives through the power of collaboration between the CDC, corporations, organizations, communities, and individuals to protect our health, safety, and security. The CDC Foundation is the only organization authorized by Congress to mobilize various partners and private sector resources in support of the CDC's essential health protection mission. Since 1995, the CDC Foundation has launched approximately 1,200 programs and raised over $1.2 billion to support the CDC's work over the past 2 decades. To keep people healthy, safe, and secure, the CDC Foundation has managed hundreds of programs in the United States, including the Overdose Response Strategy program that Jim and I are part of, along with programs in more than 160 countries. So in this slide, I'll share some more about my role as a public health analyst. And as many of you know, public health is the science of protecting and enhancing the health of individuals and their communities. This work is achieved by promoting healthy lifestyles, conducting research on disease and injury prevention, and detecting, preventing, and responding to infectious diseases. Public health aims to protect the health of whole populations, which can range from local communities to entire countries or global regions. As the Maine public health analyst, I serve as a liaison between public health and public safety and collaborate closely with my drug intelligence officer counterpart, Jim. I work across public health, law enforcement, policy, prevention, and healthcare to increase data sharing, improve overdose response efforts, and provide support to both public health and public safety ORS partners within our state. I develop a monthly report about overdose trends, which helps state and regional partners understand any potential threats. And as I've mentioned previously, public health and public safety collaboration allows for a wide range of issues to be addressed more effectively and efficiently. And with that, I'll hand it over to Jim, who will share some information about the Office of National Drug Control Policy, the High Intensity Drug Trafficking Areas Program, his role as a drug intelligence officer, and information about our current work and partners.
Hey, everybody. So we'll start with the ONDCP. Office of National Drug Control Policy. It funds different grant programs, and the one that we're going to talk about today is HIDTA, as has been mentioned before, High Intensity Drug Trafficking Areas. It isn't an agency like most people would think about a law enforcement department or agency. It's an entity, a program that was created by Congress in 1988. The HIDTA program coordinates and assists federal, state, local, and tribal law enforcement agencies to address regional drug threats with the purpose of reducing drug trafficking, drug production in the United States. Anything really drug trafficking related is where HIDTA's focus lies. And the HIDTA program oversees 33 regional HIDTAs in all 50 states, including Puerto Rico, U.S. Virgin Islands, and the District of Columbia. So nationwide, the program comprises more than 900 investigative, interdiction, and intelligence sharing initiatives. HIDTA's goals include removing drugs from our streets, dismantling drug trafficking organizations, promoting best practices and innovations, preventing substance misuse through comprehensive programming, and enhancing officer safety and coordination in law enforcement operations. So while Shasta is employed by the CDCF, my funding as the DIO from Maine comes from HIDTA, and specifically from New England HIDTA. And I think that's kind of one of the more interesting points in HIDTA, as everybody thinks in at least law enforcement circles, when people mention HIDTA, they think about enforcement. What they don't realize is that HIDTA has this whole other side, like us, the ORS. They also have a prevention coordinator for New England HIDTA, who actually, it's a brand new position. His name is Paul McNeil. He's doing great work across all 5 states in the prevention area. And he's trying to make new partners every day. So HIDTA is really kind of a multifaceted thing. And what is a DIO? So in addition to partnering with Shasta to help break down silos and encourage information sharing between public health and public safety, no exaggeration, it's so common where I am the only person associated with public safety in a meeting. And it's also just as common as her being the only public health person in a meeting full of public safety people. So it's really a great program in that way. But one of the more important functions, aside from sharing between sectors, in my role, is to promote information sharing between law enforcement agencies, which, contrary to popular belief, is not great. It's getting better, but it's not great. And I say that nationwide. A great example of that is what we call FANS, felony arrest notifications. And basically what that amounts to is anytime a non-Maine resident is arrested in Maine for drug trafficking, I collect that information and I report it back to the suspect's home state, to the DIO there. And then vice versa, when a Maine resident gets arrested for drug trafficking in another state, I'm notified by that state's drug intelligence officer. And then I pass that information along to the appropriate Maine law enforcement agency. So this creates an environment for effective information sharing between the Maine agency and the agency where the suspected offender resides, with the goal of providing investigators and prosecutors with a more complete picture of the case. And this is just a map of HIDTA's footprint across the country. And if you look at New England, you can see that our headquarters is in Methuen, Massachusetts. And each state has at least one designated HIDTA county. And in Maine, that would be Cumberland County, as you can see by the map there. And this is just a kind of a slide showing our bigger programs and initiatives that we're working on and our partners that we collaborate with on a regular basis. I'm going to skip the first two, the ORS Cornerstone Project and the Maine Drug Monitoring Initiative, only because we have 2 slides coming up on those which go into greater detail. The third one, the Maine Environmental Scan, the ORS provides the opportunity for public health analysts to conduct the state environmental scan. And this scan helps to identify all the current state efforts in overdose prevention, understand the state's surveillance and response, provides opportunities for partner introductions, collaborations, and it also, most importantly, shows any areas of need to combat overdoses. It's really a great project, something that Shasta started almost when she started, and she's wrapping it up pretty soon, actually. And the next thing on the list, the Maine Law Enforcement Drug Intelligence Report. This is a quarterly report that gets disseminated by the MIAC. And just to explain the MIAC a little bit, this is, for those of you who don't know, this is our state's fusion center. It stands for the Maine Intelligence and Analysis Center. Every state has a fusion center. They all kind of came about after 9/11 with the idea of having representatives from federal agencies, state agencies, local agencies, private partners, anything to do with critical infrastructure, all kind of in the same room to share information. So it's disseminated through the MIAC. I contribute to that, and this helps keep Maine law enforcement better informed on drug trends, concealment techniques, notable seizures, anything related to drug trafficking that we believe has a direct nexus with Maine or New England. We also assist the options program by meeting with their members of their leadership regularly to offer any support we can to the program. And more recently, we've been fortunate enough to be invited to the state's overdose fatality review panel meetings, which are very informative, again, to offer any support we can with the resources available to us through the ORS. Recently, Shasta started a project where she's begun working with correctional system staff to help support overdose prevention efforts in Maine correctional facilities. The state, as many of you know, state correctional system has done some really great things with medication-assisted treatment and offering services in their facilities to residents. And we want to ensure that our county facilities are receiving the support to hopefully implement some of those successful strategies in their areas of operation as well. We also regularly meet with the data team that provides so much great information to the Maine Drug Data Hub. And we can offer any support we can to them as well. But most importantly, we're always trying to build and expand our partnerships through the state, regionally, and nationally. We kind of have this unofficial slogan between the two of us that we'll meet with anybody just to see if we can help, you know.
All right, thanks, Jim. As the previous slide showed, one of our current projects is the Maine Drug Monitoring Initiative, known as the DMI. The DMI is a collection of information obtained from various sources and partners, including but not limited to public health, law enforcement, and EMS. It focuses on emerging threats and trends, along with additional information and news. The Maine DMI is written by the Overdose Response Strategy's Maine Public Health Analyst, which is me, with contributions from the Maine Drug Intelligence Officer, Jim, and Maine Information Analysis Center Analysts. It is distributed monthly by the MIAC and featured on the Maine Drug Data Hub for increased exposure and distribution. And this slide shows part of the November 2024 DMI, which includes a public health awareness section on pink cocaine, also known as TUSI, which you may have seen recently in the news or media. Jim will share more about pink cocaine later in the presentation. The ORS conducts cornerstone projects that mobilize the entire ORS national network to answer common questions or address shared informational needs that affect the ORS. These projects focus on a different priority topic each year and build upon evidence-based practices to reduce drug overdose. The ORS program produces a comprehensive report on the findings each year. Past cornerstone projects have included the following topics: public safety, public health, and harm reduction resources on stimulants, overdose prevention services in jails, promising strategies for implementing linkages to care at the nexus of public health and public safety, and law enforcement knowledge, understanding, and perceptions of 911 Good Samaritan laws. You can find the comprehensive reports for each of the past cornerstone project topics on the ORS website, which we'll share at the end of the presentation. And this year, the Cornerstone Project aims to improve overdose prevention services for people experiencing homelessness by examining the connection between homelessness and overdose and best practices for adapting overdose prevention services for this population. Jim and I recently started collecting data in Maine for this project, which we'll share with our national ORS team for their comprehensive report. And now I'll hand it back over to Jim to share some information on ORS success stories across the U.S.
So we thought this slide was important to show you just how varied each team's projects are across the country and some of the successes that have come from their work. One of the real benefits of the program is that the leadership truly understands that each state has specific needs, which allows each state's ORS team to tailor their work to meet those needs. Nothing is really cookie cutter with the ORS, which is great. The website has a fantastic section dedicated to these success stories, and I would highly recommend, if you're interested, to go check those out. But just a few of the highlights that I wanted to mention. Amazing work by the Connecticut team in supporting the production of Silence on the Streets, which is a very powerful documentary addressing the cycle of addiction from the perspective of inner city minorities, Native Americans. This film was funded by discretionary funding from ONDCP and New England HIDTA. The Oklahoma team recently brought awareness to public health and public safety in their state about the importance of collaborating efforts to find shelters for sex trafficking victims with substance use disorder. The Wyoming team recently collaborated with the Eastern Shoshone Tribal Health Team to better understand the community's need for overdose services and also to improve the community's access to naloxone. And as a result, the Wyoming team conducted training for that entire community on goals and opportunities, and to inform them about overdose prevention services and continuity of care as well. And then finally, I'll mention that the Kansas ORS team created a new demographics layer in ArcGIS. And this layer became an embedded part of ODMAP, which we're going to talk about next, which adds a new functionality and new data points to ODMAP, including socioeconomic indicators, and it also helps to better inform outreach, education, and response plans as well.
Thanks, Jim. Definitely some incredible work being done across the country with our coworkers in other states. So this slide has information about the Overdose Detection Mapping Program known as ODMAP, which is a free web-based mobile-friendly platform designed for near real-time reporting and monitoring of suspected fatal and non-fatal overdose events. It was developed by the Washington-Baltimore HIDTA. ODMAP aims to provide near real-time data to public safety and public health agencies. And it displays overdose data both within and across jurisdictions, helping agencies identify spikes and clusters of suspected overdose events in their community, neighboring areas, and across the country. ODMAP is available to all federal, state, local, and tribal agencies that serve the interests of public health. In Maine, over 85 state, county, and municipal law enforcement agencies are registered to collect overdose data and report it to ODMAP. The state supports the utilization of ODMAP by law enforcement agencies, as well as the sharing of overdose spike data with public health officials, clinicians, and community partners. Maine submits suspected overdose data to ODMAP through a statewide application programming interface with Maine Emergency Medical Services. and additional suspected overdose events are entered into ODMAP by law enforcement agencies around the state. The overall goal of ODMAP is to utilize this public safety overdose data to organize public health efforts to mobilize an immediate response to a sudden increase or spike in overdose events. All that being said, we believe that ODMAP may not be being used to its full potential in Maine, and the ORS has a unique relationship with ODMAP as one of the earliest supporters of the tool and a provider of feedback on implementation and utilization. Our team is here to support any Maine public safety and public health agencies interested in using ODMAP as a tool for sharing data systems or to help develop strategic plans for preventing and responding to overdoses. And this map shows how widespread ODMAP engagement is at the national level. As of July 2024, approximately 5,200 agencies across all 50 states, the District of Columbia and Puerto Rico are using the platform. Over 2.6 million overdose events have been entered into ODMAP, and 34,800 individuals are registered to use ODMAP. And Jim will wrap up our presentation today by sharing some information about current drug trends.
Okay. So yeah, let's talk a little bit about some current drug trends we're seeing in our state and in the New England region. So we'll start, for those who aren't familiar, the Maine Health and Environmental Testing Lab, among all the other really important work they do, they're also the only laboratory in Maine that tests substances seized by law enforcement that are headed for prosecution. So in other words, they test all the evidence that are seized by Maine law enforcement that are going to be used in a case. In 2023, we entered into a memorandum of understanding between the Health and Environmental Testing Lab, the MIAC, and us, the ORS, that allows us to view the results of those tests and then create an executive summary. And what we've done is we've put that we just started actually, I think a month or two ago, we started putting that executive summary in Shasta's monthly DMI, which is posted on the Maine Drug Data Hub. So it's probably no surprise to anyone listening that, like most states, most commonly encountered substances seized by law enforcement and then subsequently tested by the HIDTA are fentanyl, methamphetamine, and cocaine. There's a fair amount of those tests also being positive for xylazine. And it should also be noted, again, probably to no surprise, that it's very common in these tests for 2 or more of those substances to be present in the same sample. On the subject of trends, I just wanted to start before we go any further into it by saying that Maine is the end of the road, not just geographically, but when it comes to drug distribution as well. We're not, nor have we ever been, a major drug distribution hub, more of an endpoint or a destination. So with that being said, it's sometimes helpful to start on the West Coast or on the Southwest border and begin moving east, looking at what other states' law enforcement and harm reduction communities are encountering, and then try to be prepared and informed in the event that that substance or that trend becomes popular here in Maine. So some of the substances that we have been keeping our eyes on, and again, not to say that these are trends in Maine, just something that we've been looking at and following. The first one I'll bring up is BTMPS. It's commonly referred to as Tinuvin 770. That's TINUVIN. This is the latest substance to appear as an adulterant in fentanyl. And the strange thing is, it's really not a drug. It's a light stabilizer used in plastic productions. Communications regarding BTMPS first began this past summer. It emerged originally in Portland, Oregon, and then Philadelphia. Interestingly enough, about Philadelphia, that's also pretty much ground zero for where xylazine started in the continental US. It originally became popular in Puerto Rico and then Philadelphia. There are way more questions than answers about this one, which is all the more reason for us to pay close attention to it to see if it becomes a trend or if it's just kind of a spot on the map that fades away. I don't know yet, but we are watching it. The next one I'll bring up, medetomidine, belongs to the same family of drugs as xylazine, and it's synthetically manufactured as well. It's available for use in veterinary medicine, just like xylazine. And apparently the effects are very similar to xylazine, with the only difference reported being that it seems to last longer in the body than xylazine. Next one I'll mention is the class of drugs called nitazines, with isonitazine being one of the more popular ones. These are very strong synthetic opioids. They were first developed by researchers around 60 years ago, believe it or not, as an alternative to morphine. But because of their high potential for overdose, they were never brought to market. So nitazines have been connected to a number of overdose deaths worldwide. Carfentanil, which you've probably heard of. This is another synthetic opioid. It's approximately 10,000 times stronger and more potent than morphine, and usually at least 100 times more potent than fentanyl. So it's pretty obvious why we would want to pay attention to that. 2C, as Shasta mentioned earlier, pink cocaine. This is a new thing that's been popping up a lot in the news lately, as well as in our circles. This is a drug concoction it started in Latin America and in Europe in the club scene. It's now beginning to gain popularity in the US. 2C is a phonetic translation of the number 2 and the letter C, which is an actual class of drugs. But in reality, there's usually no 2C class of drugs in this combination. It's marketed by drug traffickers as a drug similar to ecstasy, which is probably why it's popular in the club scene. It's sometimes referred to as pink cocaine, even though it doesn't always have cocaine in it. It typically comes in the form of a very bright pink powder. And multiple drug checking studies recently have found that the majority of the 2C samples submitted actually contain ketamine as the main drug, often combined with MDMA or any other ecstasy-like drug. Methamphetamine, sometimes cocaine, sometimes fentanyl or other opioids, and sometimes some novel psychoactive substances as well. So this is hugely problematic for all the reasons I just said, because somebody can be, taking one batch of 2C one day and then the other batch, another day, and they could be completely different drug compositions, which obviously can lead to overdose situations. And then the last thing I'll mention before we move on to the next slide is K2 or Spice. These are just two of the very many trade names or brands for this synthetic designer drug, which is intended to mimic THC. These are these synthetic cannabinoids, and they're not new. They've been around forever. Sometimes they're sold as herbal incense or potpourri. The reason I bring it up is because there's been a lot of buzz recently across the country about the increased use of these drugs by incarcerated populations. So it's something, again, that we're really keeping our eyes on. And then I've broken up the next two slides. First, we're going to talk about pills, and then we're going to talk about powder. And I just have some pictures, and I want to show you, and I want to tell you a few of the things that I find interesting about these pictures and related to these substances. So we'll start with pills. In 2023, DEA forensic lab analysis showed that approximately 7 out of 10 fake pills contain a potentially deadly dose of fentanyl, which the DEA estimates to be approximately 2 milligrams. But they also note that their fentanyl profiling program documented pills that ranged from 0.03 milligrams all the way up to 9 milligrams. So it really is a mixed bag. And if you look on the left of your screen at the M30 pills, the ones on the top are fake. The ones on the bottom, you can see a comparison between authentic and fake. Right next to Adderall, again, real and fake, and then Xanax, again, real and fake. And it's just, I felt that this was an important picture to show just because it's alarming how real the fake pills look. Whereas you're not getting oxycodone, Adderall, or Xanax, you're getting fentanyl, methamphetamine, or fentanyl, so it's just scary. And then in the middle, we look at bromazolam. This is a new, you can see there's 2 pictures of bromazolam. This is a novel designer benzodiazepine. It's synthetically manufactured. There's a lot of unknowns about the health risks here. I can tell you, and you'd see in the executive summaries, that we have found bromazolam in Maine. It's oftentimes mixed with fentanyl, and then on the street it's referred to as benzo dope. And Interestingly, it can be encountered in 3 different forms. The green pills seem to be the most popular, but it's also been found in powder and liquid form as well. And then moving on to beneath that, the tianeptine, which is also referred to as gas station heroin, is legal in most states. And matter of fact, when I was researching this, I found a link on Amazon to be able to buy it. It's been marketed for everything from treating anxiety and depression to better brain health, but in larger doses, it's abused for its euphoric properties, which reports say are similar to opioids. There's a lot of severe adverse health effects related to it, including respiratory depression, severe sedation, and even death in a few cases. I can tell you that as of the beginning of this month, beginning of December, North Carolina has gone through legislation to have this scheduled in their state. It becomes difficult. Some of these newer compounds that aren't scheduled reminds me of when bath salts first came to Maine. If there's no statute that allows for law enforcement to seize this or take action on it, there's really not a lot that they can do in those cases. And then on the right, both of those photos are from seizures in Maine. One of them is from Western Maine, one of them is from Southern Maine. These are pressed pills. We see them pretty commonly in different brands. They can contain anything, as you might imagine. I can tell you that one of this sets is a methamphetamine pill, and the other one is MDMA or ecstasy. So the concern here is it's for a lot of different reasons. Number one, you don't know what you're ever getting. Number two, they look like chewable vitamins, which can be confused for somebody who has no intention of taking these things. So those are just some of the common things we see with pills. And then moving on to powders, these are all Maine photos, and I put them here for different reasons. The one on the left, actually the one on the left and the one on the bottom middle, I wanted to illustrate that for a very, very long time, like a very long time, drugs for guns is a very common thing. If you have a drug trafficker from a state where it's not as easy to get firearms, they'll oftentimes work firearms acquisition into the drug trade. The other reason that I put both the one on the left and the one with the black wrapping on the top is just to illustrate that, you know, when I was a patrol officer, it was common to get an ounce maybe, and you'd feel really good about what you've done there. And today we're seeing pounds being seized in Maine, which is for obvious concern. I'm sure we've all heard about colored fentanyl, rainbow fentanyl, things like that. You can see from the pictures, the green and the pink, those are common colors that we seize here in Maine. Sometimes also purple and gray show up in our Maine illicit drug stream as well. And then the last thing I wanted to point out was the green and the picture below it, those cylindrical wrappings. Those are commonly encountered by Maine law enforcement. Those are on the street either referred to as sticks or fingers. These are generally 10 grams. They're usually fentanyl. And it's just a very common packaging method that we see here in Maine.
Thanks for sharing all that great information, Jim. And with that, we'll wrap up our presentation. Just a big thanks to all of you for listening. And thank you to all our professionals across our state who are doing the hard work to reduce drug overdoses. Your work's essential and very much appreciated. For additional information, don't hesitate to get in touch with Jim or myself. Scan the QR code that you see here, or visit our website at orsprogram.org. Thank you.
Well, thank you, Shasta. Thank you, Jim. And while I'm not seeing any questions, I have quite a few. So I'll be happy to start, and then people can put questions in the question and answer spot if they have any. Mine are kind of general. We haven't rehearsed them, so I don't mean to put you on the spot. So what do each of you worry about the most as we approach 2025? You know, is it the prospect of carfentanil? Is it more adulteration of fentanyl by sedatives? Is it pills? What do you, in Maine, what should we be most worried about? What keeps you up at night?
Shasta, can I take that one first?
Yeah, definitely.
Okay, so for me, the DEA recently, and I would encourage anybody who's really truly interested in drug trafficking to check out the DEA website. They've just released their most recent threat assessment publicly, and it's a fantastic report on. It starts with the cartels. It moves into, how drugs are trafficked across the country. It's very informative, and I would recommend anybody who's interested in that to read it. But that being said, one of the comments that the director has made publicly is that they're seeing a decrease in the potency of certain fentanyl pills, for example. I'm sure you could apply the same logic to powders as well. This is of to me, great public health concern in the sense that you can have somebody who's pretty sure that, we'll just use the example of one pill, will do what they want it to do for them. And then that pill becomes weaker, so they take two, and then it becomes weaker and they take three. So now if we have somebody who's using fentanyl and they feel like this weaker concoction, is allowing them to take, we'll just say 5, 6 pills, whatever, and then the concentration bumps back up, we're going to have a spike in overdoses, and that's a problem. It's a huge problem, and it's not like we can go to a pharmaceutical manufacturer and say, hey, fix this, right? And I don't know what the answer is here. I can just tell you that cartels have no interest in public health or public safety. They have interest in making money. And how they do that can vary from month to month, week to week, day to day, from cartel to cartel, from smaller group to smaller group. The amount of adulterants added or not, it's just such a mixed bag. So the unknown, I guess, is what keeps me up at night, Gordon.
Shasta, and then I did find a different place on my screen where there are some questions. So, but
Okay.
Shasta, I'll let you answer this one first before I go to the written questions.
Okay, yeah. I mean, this is like a great example of how Jim and I see things differently. For me, on the public health side and clinical social work side, I think Maine has some incredible resources, some people, like incredible people working really hard, so many of us and out there. But I'd like to see individuals have better access to the resources available to them. And there are a lot of resources out there in Maine. And additional prevention efforts for our youth and families. Short answer.
Yeah, no, well, again, that's, we could spend today on prevention. I mean, as you know, our work here in my office has always been focused on the 4 pillars of prevention, treatment, harm reduction, recovery support. The Recovery Council recently, in those 43 projects that they supporting financially, have tried to balance those between the pillars. And so you wish you could put all your resources into prevention, because that's where we really get the most bang for the buck, is we can have fewer of our adolescents start down that road. So do not think for a minute that we're not working on that. You always could always use more resources, because it's prevention never gets its due, partially because in terms of resources, because you don't see an immediate impact. It might be a generation before we see a marked improvement, and that's okay. But our policymakers in Augusta and in Washington, they're elected every 2, 4, 6 years, and there aren't any magic bullets that all of a sudden can fix this quickly. But let me move rapidly. We got about 10 minutes left, and I found some questions. So Brad wants to know the best way to determine the fake pills. Notes that he thinks it is a real problem, and wants to know how we can determine whether a pill is fake or not. That's a tough one.
It's a very tough one, and I think I don't want to be doom and gloom and say that there's not a way, but in reality, looking at them, there isn't a way. So unless you have a drug checking apparatus that you can access, I know, for instance, if you're interested in drug checking programs, you should look to the MADS program in Massachusetts, where it's a publicly available drug checking program where people can bring in whatever it is, even if it's powdered fentanyl, and have it tested to see exactly what's in it. So that's one thing. But short of that, I would say pay more attention to where you're getting your substances from. If you're not getting your pills from a legitimate pharmacy, I wouldn't personally, me personally, would not trust them if it's not from a legitimate pharmacy.
That's a good answer, Jim. I would add that in the presentations we've received, these pills can not only look just like a pharmaceutical grade pill, but they could have the name of the pill on it. So you could think, you might be on a college campus, think you're going to stay up all night, take some Adderall, and pay $20, get an Adderall pill. It says Adderall on it, but it's not Adderall. And, it could be fatal. We know that, as Jim says, 5, 6, 7 out of 10 pills that are fake have a lethal dose of fentanyl in them. So there isn't an easy way. I would say that, we're gradually getting into the drug checking business, that under Project Dharma, that's supported by the federal and state dollars now, there are 4 new drug checking machines in 4 of our syringe programs. There's one in Sanford, there's one in Calais, not sure where the other 2 are. But right now, we're testing residual amounts of drugs left in syringes. But I'm not sure the capacity of those machines for somebody to be able to walk in with other than that. But I can get an answer on that. And so we do have these 4 new machines, and those were supported by this federal grant. Those machines are about $35,000 each. So we will begin to have the kind of information that Massachusetts is getting. I think that's all I'll say about pills. It's interesting because we have had seizures of pills in Maine. There's no question about it. Although we don't have a known case of a person overdosing on a pill. The reason, though, be careful of what I just said, because we don't know the mode of injection or inhalation. We don't know. We only get the if a person dies, we get the toxicology test of the substances in the body. I don't know whether that substance got there through smoking, inhaling, boofing, oral ingestion. Now, there may be obvious indications of intravenous drug use on that body, and that may be in the chief medical examiner's report. But it's interesting to me because I started inquiring in our weekly overdose reporting about that. Gee, how come we've never seen it? If we're worried about these pills, how come we've never seen an overdose associated with a pill? We don't. The fact is that our data sources are not such that we know that, and it's something to think about. Let me get to a couple other questions. Dan asks, this really one for you, Jim. How many drugs are entering Maine through the Canadian border?
Well, actually, I just read that one. And I think a lot of people would be surprised at how transparent a lot of law enforcement agencies are. For example, I explained to you that the DEA put out this very informative guide. MDEA has a great Facebook page where they will post some of their more notable seizures, where you can see, form and packaging and things like that of what's coming in. Along the same lines, U.S. Border Patrol posts all of their seizures. And if you look at the Holton sector, that's what they call it. It's basically our section of the border, whether it's Holton or not. There's very little. There's very little seized coming through the Canadian border. We know that this is, again, you can reference the DEA website if you want to get more into it, but we know that almost all fentanyl and methamphetamine are coming from the southwest border. Cocaine takes different routes. Again, you can find this out on their website. Sometimes it comes in through the southwest border. Sometimes it comes through freight or air or shipping, you know, whatever the case may be. But that obviously always comes from South America because that's where it's grown. But there's very little, I'm sure a lot of people on this call can remember the days when you'd see on the news meth labs being taken down in Maine. And, you know, one of the things that I would say about that, number one, is that a meth lab can be as simple as a 2-liter soda bottle. It doesn't have to be something out of Breaking Bad or anything like that. That's very rare today because higher quality methamphetamine produced in Mexico is cheap and it's easy to get. So there's very little. I saw something in the chat, how much is being produced in Maine? I would say very little. That being said, you have some of these designer drugs that are not coming from the southwest border. They're clearly coming from the dark web, from black market websites, things like that, and shipping. Personally, again, speaking for myself, those are of a little bit less concern to me because we don't generally see them in higher quantities as we do fentanyl, methamphetamine, cocaine, things like that.
There's a few. There's one easy question here. I think I'm not. I think that you had mentioned about tianeptine. I think I'm pronouncing that right. And so some people wanted a little more information on that. You had said that you had checked and it could be bought online today. It's not illegal in Maine. That's true, and I know that because there was a bill in the legislature 2 years ago that would have made it illegal. There was a legislator who presented that bill. It came to the health committee. It failed. So while it may seem obvious to the 100 people on this webinar today that, well, that's a no-brainer, let's make it illegal. You know, nothing's easy over here. Maybe that legislator was reelected. He might choose to bring that bill in again. But there's so many things from so many sources, whether it's a gas station or the internet. But Jim makes a great point that, you know, yeah, 1 year there were over 50 meth labs taken down, and that's a very expensive proposition because the hazmat team goes out from the DEP to do that. Now there's almost none because you can just get a higher quality through and get it delivered to your house through either FedEx, UPS, courier. So you try to stay one step ahead of the cartels and the traffickers, but there's nothing easy about this. So let me see. Yeah, let me see. Oh, this is a good one. And has there been any discussion to get information on the trends, on the drug supply trends, such as xylazine contamination, which is right now we're seeing that at about 14% of our drug deaths involve some amount of xylazine, pushed out to local health officers and public health officials through the CDC district liaisons, boots on the ground providers, so that people doing the work, the people that are on this webinar, are aware of spikes that might result in an increase around wound care, et cetera. That is what is happening now. I think we've just not been good enough to let you know that the report now, the Maine drug monitoring initiative that Shasta is putting together. As soon as we get that, we put it on on our drug data hub, mainedrugdata.org, that is capably maintained by the Margaret Chase Smith Policy Center staff. And so, you know, if you're not regularly going to look for the monthly drug data, you know, our monthly overdose report for October was placed on the hub on Tuesday, for instance. And so if you're not a frequent visitor to that, there's all kinds of data, all kinds of reports. And so we are trying to get that out to people, perhaps we should work with the CDC, though, to make sure that we push some of that data out to you so that we're not relying upon you to all of a sudden in the middle of the day think, gee, I ought to be checking the hub today. It would be relatively easy, for instance, when some things are reported for either Shasta or the team at RNO to send that to the district liaisons, for instance, or send it to the CDC and ask them to send it out.
And Gordon, anyone can always email me, and I can have them added to the distribution list so they receive it by email. And perfect. The most recent one should be out sometime next week.
Great. Do we know, have we given them in the chat or anything your email address, Shasta?
It was just at the end of the presentation, but I can put it in the chat.
All right. Why don't you put that in the chat? And while you're doing that, I will just thank you and Jim for the presentation this morning. We are at 12:31. I want to always thank Lorena and AdCare for putting these, doing the technological work for us. But most of all, thank you for the 100 of you that took time today out of your busy schedules to hear this information. And thanks for being such great partners. We'll be together again on the first Friday in January. It's possible, because that's a couple of days after New Year's, that, you know, we might blow by that to February, but watch for our announcements. We'll probably do it so that we don't lose our momentum. And thanks for everything you're doing. Have a great holiday, and we'll see you in January, probably.
Thank you, Gordon. Thank you, everybody.
Thank you, Gordon. Thank you, everybody.